Hello, everyone. Today I come to you with another special presentation. And to begin with, I'd like to refer you to the picture in the background that talks about never treat a stranger and never kill a friend. And what that means is that when you meet somebody, you have to interrogate them regarding their risk for blood clots. And then once you do, you know enough about them as you would perhaps for a friend. So, of course, you would never treat a stranger, but you sure as heck would never kill a friend. And I'd like to reintroduce today the participants in this very important symposium. And the reason why I think that this is really important and important to refer to the fact of never treating a stranger or killing a friend is the treatment of varicose veins. And there's 45 or 50 million people with varicose veins. It's a big area for treatment, and it's very important because most of these, it's a low-risk procedure. Most of these will go just fine. There'll be no problem. But every now and then there's a disaster. And in order to avoid those disasters, you have to interrogate people. And so you never want to treat a stranger for varicose veins without interrogating them. And once you do, then they would be like your friend. So today we have with us Kirill Lobostov, who's Associate Professor of the Department of General Surgery, Russian National Research Medical University, Pirogov, and the Scientific Director of the Thrombosis School Educational Project. He has a long history of working on venous thromboembolism, patient awareness, teaching about the Caprini score, publishing landmark papers regarding that. And I welcome him today with yet another presentation. And after his presentation, we're going to have another presentation, which I will then talk about with Tomasz Urbanek, who's a professor of vascular surgery at the University of Silesia in Katowice in Poland. Again, a long history of venous thrombosis awareness, interested in deep vein thrombosis treatment and diagnosis, and also chronic venous insufficiency, and done a lot of work with the Caprini score and done more to promote the score, including a fabulous work that he and Kiri did together about the thresholds for the Caprini score in various populations. And again, these two gentlemen are emblematic of why this score is so successful, because people from around the world have explored it, used it in their own populations, found out where it worked, found out where it doesn't work, and so forth. So without further ado, I'd like to turn it over to Kirill to start with the first presentation.
Thank you very much, Professor Caprini. It's a big honor to be here to present these results of the Caprini score validation in modern mini-invasive varicose vein surgery. And ladies and gentlemen, let me introduce you the interim results of our CAP6 trial. It is an ongoing registry trial which is aimed to validate Caprini score in modern varicose vein surgery. And recently we have published this data in two papers, one paper in the International Angiology Journal and the second paper in the Phlebology Journal. The first one is focused on the risk factors and the risk assessment and the stratification of the patients according to the Caprini score. And the second one is focused on the anticoagulation, the use of prophylactic anticoagulation, and the efficacy of such approach. This is a registered trial, a prospective trial, which includes any patient who underwent any kind of varicose vein procedure, but modern procedure. It may be open or endovascular, and but every patient should be assessed by the duplex ultrasound to find asymptomatic deep vein thrombosis within 2 to 4 weeks after the intervention. And we look for any VT events that includes asymptomatic DVT, symptomatic DVT, and the venous heat-induced thrombosis and bleeding events as well if patients receive some anticoagulation. And the first analysis was done in February 2022, and it includes records on 1,878 cases. And for today, the study is continuing, and in January 2024, we have more than 3,000 records. and we plan to achieve the final amount of 5,000 records in a few years to make the final analysis of this data. So this analysis includes predominantly patients with C2, C3 subclinical classes. So it is simple varicose veins or varicose veins with edema, and less of patients with progressive chronic venous disease, with trophic changes. The main affected vein was great saphenous vein, which was predominantly treated by endovenous laser ablation. And what is important, only 40% of all patients were treated with phlebectomy or sclerotherapy for the varicose tributaries, and about 60% of all they were not treated, and these tributaries were left for the further spontaneous regression. And in most cases, the procedure was done under local tumescent anesthesia in the outpatient facility, so it was rarely a one-day office surgery. This is a distribution of the risk factors by the classical Caprini score of 2002. And as you can see, of course, it's a very non-complicated surgery, and patients have not a big amount of high risk factors. So usually they have varicose veins, swollen legs, maybe increased body mass index, maybe some kind of individual or family history of venous thromboembolism. So the mean Caprini score is not very high, it's just 4, but it ranges from 1 to 12. So there is also some patients with a very high Caprini score, which in general surgery means extremely high risk, and so that's patients in whom the standard prophylaxis may be not very effective. In our study, all patients received some kind of elastic compression for the median of 4 weeks, but only 20% of them received any prophylactic anticoagulation with low molecular heparins or direct oral anticoagulants, with a median duration of 3 days and interquartile range from 2 to 7 days. So it was a really short time of prophylactic anticoagulation. And what we saw as the result of our trial. So NVT event was observed in 3.4%, and it included asymptomatic deep vein occlusions in 29 cases, symptomatic occlusions in 10 cases, and endovenous head-induced thrombosis in 28 cases. So most of these cases were asymptomatic, and the incidence of symptomatic deep vein thrombosis was only 0.5%, and we did not see any pulmonary embolism. So no pulmonary embolism was detected within these 28 days follow-up. And finally, we found the significant correlation between the Caprini score and the incidence of postoperative VT. You can see it from the diagram. So it started from 2.2% in the Caprini score of 0.2 to 25% in the Caprini score of 11-12. So it's the same nonlinear correlation that could be found in any other surgical procedure. So finally, we understand that modern varicose vein surgery is associated with the same risk of postoperative VTE like all other surgeries where Caprini score was previously validated. When we looked at different risk factors for the development of postoperative VTE, we found one very paradoxical thing, that chemoprophylaxis, use of prophylactic anticoagulation, had a negative correlation with the incidence of postoperative VTE. So patients who received anticoagulation, they had a higher risk of postoperative VTE. And we decided to look deeper in this issue and find out the reason of this paradoxical correlation. And what we found out, the first thing was that patient who received just one single injection of low molecular heparin just at the day of the surgery, they had a risk of postoperative VT 2 or 4 times higher than those who did not receive any kind of prophylaxis, any kind of prophylactic anticoagulation, or those who received prophylactic anticoagulation up to 7 days, so the prolonged prophylaxis. And this is very important. So our data shows that one single injection of low molecular weight heparin, it does not protect for any kind of postoperative VT. So the risk is maybe not very high in the view of symptomatic events, but if you consider the impact of asymptomatic lesions, so in this situation, just one injection of low molecular weight heparin will not help you to prevent it. Another paradoxical issue was that prolonged anticoagulation was associated with a higher risk of postoperative VT. However, prolonged anticoagulation was administered predominantly in patients with individual history of VT, in those who previously had DVT, PE, or even superficial vein thrombosis. And according to the design of our study, it was a registry. So we cannot say if this prolonged anticoagulation was driven by the fact of detection of this asymptomatic lesion. So, for example, at 2 weeks after surgery, physician find endovenous heat induced thrombosis, and this drives him to prolong anticoagulation for 30 days. Or maybe these events occurred at the background of this prolonged anticoagulation. Unfortunately, we cannot make any strong conclusion on this topic. But however, we believe that these patients with personal history of VT, they rarely need a prolonged anticoagulation up to 30 days. Another very interesting thing that we found out when we compared different types of anticoagulation is that direct oral anticoagulants were associated with a lower risk of postoperative VT when compared with no anticoagulation and when compared with low molecular weight heparins. The reason for such finding may be due to only low molecular weight heparin were used just a single injection in the day of surgery. No dose was used in such approach. And the another thing, when anticoagulation was prescribed for prolonged period, maybe low molecular weight heparin had a lower compliance. So it is impossible to assess in the registry trial if the patients really used this low molecular weight heparin, which were prescribed for 7, 10 days, or even 30 days. So dogs in this point of view were better. But however, this is off-label use because no official instructions of any direct oral anticoagulants include this indication. So after that, we excluded patients who received any prophylactic anticoagulation, and there was a sample of 1,498 patients, and they had the same incidence of asymptomatic and symptomatic VT, and the correlation between the Caprini score and the incidence of postoperative VT was also significant. And according to the regression analysis, the most important risk factors which were associated with the development for postoperative VT were Caprini score, removing of varicose tributaries or perforating veins, in combination with the ablation of the main truncal vein. So if the procedure was more extended and accompanied by removing of varicose veins, it impacted additional risk to the development of postoperative VT. So according to this analysis, we suggest the risk stratification according to the Caprini score of patients into 3 groups. Low risk, it's Caprini score from 0 to 6, and the risk even without prophylactic anticoagulation is low, and prophylactic anticoagulation may be not required. Moderate risk, it's from 7 to 10 Caprini risk scores, and the VT incidence is elevated, and these patients may be candidates for prophylactic anticoagulation, especially if they have some additional risk factors, particularly treatment of tributaries and perforating veins. And the high risk, it's 11 and more Caprini score, and in this situation, of course, the prophylactic anticoagulation is indicated. And a special attention needs to be paid to patients who already had some history of venous thromboembolism, including deep vein thrombosis, pulmonary embolism, and superficial vein thrombosis, because such patients has also elevated risk of postoperative VT, and short-term anticoagulation is not effective in this situation. They require prolonged anticoagulation. And it is interesting that for today we have a new trial which started in United Kingdom, and it is a thrift trial which also compare different anticoagulation strategies in such patients. No anticoagulation at all, one injection of low molecular heparin and prolonged anticoagulation, and they will assess the incidence of postoperative VTE within 90 days after surgery. And when they calculated the sample size, they assumed the same incidence of postoperative VTE like in our trial. So it's combined symptomatic and asymptomatic, and without anticoagulation, it's 2.7%, and with anticoagulation, it's 1.0%. So it's absolutely complementary to the results of our study. So, ladies and gentlemen, I would like to conclude that actually the risk of symptomatic VTE after modern varicose vein surgery is low. It's just 0.5%. But if we consider importance of asymptomatic VTE, it may be 3.4%. And according to the Caprini score, actually we can divide patients into the risk groups, and some of them rarely requires prophylactic anticoagulation, but it should not be just one single injection of low molecular heparin after surgery. Thank you very much for your attention, and I will be happy to discuss this topic.
Thank you very much, Kiri. And now I would, you raised some very important points, and we'll come back to those. But now I would like to introduce Tomas Urbanek with some reflections on this study and his own observations. Tomas?
Thank you very much for this opportunity. I think that study which was presented by Kirill gives us a lot of information, and also will simplify the approach to this patient, especially in the era of the minimal invasive treatment, because in reality we do not have good guidelines, and we still have the problems how to treat the patient with varicose vein surgery, and even bigger problems how to provide the proper VT prophylaxis for endovenous treatment. We know that in many countries and centers, most of the patients are treated with minimally invasive tools, but who of the patients should receive prophylaxis? For how long? What kind of prophylaxis? In most of the cases, up till now, this was the extrapolation of general surgery guidelines. But according to this study presented by Kirill, it seems that we can select the patient with the higher risk requiring prophylaxis, adding also to this risk assessment approach the factors which we probably never included before, even if we thought that the kind of the procedure, the extent of the procedure, the kind of anesthesia matters. We knew this from general surgery studies, but it's relatively poor knowledge regarding this concerning the varicose veins surgery and minimally invasive treatment. And let's look into the study details, which was presented already by Kirill. But what was the group of patients which underwent this kind of analysis included into Capsivis trial? They were mostly C2 patients, some C3, C4, mostly great saphenous vein treatments, so almost 95% treated by minimally invasive, especially thermal methods. So we speak about the modern phlebology approach, so not very much advanced patients, mostly treated on great saphenous vein competence, mostly with thermal methods, very few treated with standard surgical procedure. However, quite significant number of patients underwent concomitant tributary treatment. Of course, the ways of anesthesia, like in minimally invasive two-method anesthesia, so no patients immobilization, and only 20% of the patients with VT pharmacological prophylaxis. Here already we have the question, should all these patients really receive pharmacological thromboprophylaxis? Probably according to the study results, as we see not, but we should focus on the patient, which are the patient at risk, and which are the patients which we should select for the thromboprophylaxis. And here are the results which for some of you can be obvious that we have quite a low rate of the VT in symptomatic VT in minimal invasive varicose vein surgery, because as I mentioned, 95% of the patient with saphenous vein competence treated by thermal methods. So it's understandable that we have a low rate of 0.5% of symptomatic VT. However, if we look into the asymptomatic cases, the total number of VT cases increases significantly. And if we look into the population, why the numbers, especially symptomatic numbers, were so low, one of the important answers is that in this study we had almost 90% of the patients at low risk category, which means that patients which probably mostly did not receive prophylaxis and with low rate of the symptomatic events, and also not as high rate of asymptomatic cases. In this study, we can identify 12% of the patients with moderate risk and only 0.42% of the high-risk patients. But probably the most important is to identify these patients which are at high risk, and also patients from the moderate risk group, which should receive prophylaxis according to the validated and proper VT risk assessment in this clinical situation. If you look into the literature regarding the DVT rate in varicose vein surgery, there are the studies about the open surgery. In retrospective studies is 1% or even less. If you look into the prospective studies right now, we have still few of such studies, open varicose vein surgery and imaging study confirmed DVT. As you can see, the number are a little bit higher, reaching up to 5% according to the first of the mentioned studies. In thermal ablation, the general view is that we have very, very low rate of DVT, mostly less than 1%. But does it mean that we should be not worried about this complication? Probably it's not true, and probably among this big group of the patients, we'll find a lot of low-risk patients, like in the study presented by Q, 87% of the patient with low-risk category, but you will find also the patients where the risk will be significantly higher. And if you look into the big epidemiological data, there are the UK hospital episode statistics. There are some information which confirmed the information received from the study presented by Q. For example, looking for clinical symptomatic VT rate after varicose veins surgery treatment. If you combine the treatment and the venous laser plus phlebectomy, I mean combined treatment with two procedures in one patient or reoperation, it gives us significantly higher rate of VT episodes. And we have also several factors which are not included in the typical Caprini score, which we should probably add in the point where we have other risk factors, which is at least 1 point per each individual factors. Another study from Dr. O'Donnell from US published in GVS Venous and Lymphatics, more than 130,000 patients from the healthcare system, and the adverse events including DVT within 30 days. And look at the DVT rate in a real-world clinical studies settings in the countries like US. Laser ablation DVT rate up to 30 days is 3.1%. Multiple therapies, a combined treatment, over 3%. Even for surgery, this is 2.4%. So we see that the number of patients affected by VT in this kind of, let's say, minimal invasive and low VT risk procedures, as we think quite often, is in reality much higher. And we for sure have patients with the higher risk of thromboembolic complications also in this clinical scenario. Second conclusion, prescription of prophylaxis anticoagulation is highly based on individual VT risk. Yes, it should be like this, but the question is still how to identify the proper factors except the Caprini score listed factors. And some of these factors were mentioned by Kirill in his presentation. Here are the predictors for pharmacological prophylaxis. Of course, not all of them listed in the Caprini score, because if you look for the original Caprini score and for individual patients, if we have age over 40, minor surgery, and varicose veins, we already have patients looking for the original score with high risk of varicose veins. But of course, there are several questions concerning this. Should we use the standard thresholds? And Kirill documented that there should be probably different thresholds. So for intermediate risk patients, 7 to 10, and for your high risk patients, 11 and over. So first is the threshold value, which should be probably modified. And second, as you can see, there are several factors which are not mentioned and should be probably included in our individual risk assessment, like, for example, bilateral leg surgery or endovenous treatment. If you operate both legs, which happens quite often, the risk of VT is much higher. This is the study which we did in Poland, published in 2020. 140 patients undergoing standard surgical procedure, great saphenous vein stripping. This is still the only reimbursed procedure in Poland, in spinal anesthesia with routine low molecular heparin thromboprophylaxis, and ultrasound was done 10 and 30 days after the procedure. DVT rate 3.5%, including asymptomatic cases. But what was important, that Caprini score was one of the important predictive factors, which for me is obvious. It is the surgical patient, but also two other factors which are not included in the general assessment, as we usually do not think about so often. So C-class and also venous clinical severity score as the predictors for VT occurrence. So generally disease advancement. Both of us include in the routine VT score, in VT risk assessment, the advancement of the disease. Do we treat in the same way the patients with C4, 4 and C2, C4 and C6? Probably we should include also this factor. And then last, what I wanted to mention, the duration of the prophylaxis. Short-term anticoagulation prophylaxis probably does not work perfectly, and in some of the patients will have a longer time of the prophylaxis needed, as Kirill mentioned. And here are the data which we already saw. The risk of VT was very high in the patients which received just one-day prophylaxis. So we should rather go for standard 7-10 days, or in some particular patients, like after VT, this highest risk patient, for even longer prophylaxis. However, this, taking into account the size of the group with the high risk in the CAPCV study, should be probably confirmed in the larger group of the patients. So to summarize, individual risk assessment, including the factors related to the procedures, but also the patient studies, the patient status, rather selective prophylaxis, not all patients, but according to individual risk evaluation. If required, for now, rather low molecular heparin plus early mobilization in compression. But of course, the studies with drugs are promising. However, none of this drug is registered for prophylaxis in surgical patients. How long? Kirill tried to answer this question. And we should work also on the proper thresholds for this particular group of the patients, I mean, minimally invasive and varicose vein surgery. Thank you very much.
Thank you very much, Tomas, for a very thoughtful and interesting presentation and analysis. I'd like to ask Kiri about his thoughts regarding this.
Thank you very much, Thomas. It's a really very clear summarizing of all data which we have in real world practice in clinical trials. And I believe that in nearest future, when all these maybe randomized clinical trials will be finished, we finally get these results, because THRIFT trial is also trying to make some additional validation of the Caprini risk score in varicose vein surgery. And finally, we will find these absolute thresholds which requires anticoagulation. But what I want to stress attention on is that thresholds for varicose vein surgery, as you mentioned before, are rarely different from the general surgery. And if in general surgery we say 5 scores, it's high, it's patient who requires anticoagulation with compression to prevent postoperative VT. So in varicose veins, 5 scores, it's still low risk, and actually patients does not always require anticoagulation with this Caprini score at all. So rarely we need more data, and I believe that in the nearest future we will get them to make final conclusions.
Well, thank you very much, Kiri. I would like to emphasize several things. And first of all, in 2012, Alton published 30,000 patients from the VA database who had surgery. And at the time, there was a surgical care improvement project in the United States that everybody that had surgery, if they didn't have a contraindication, had to have a shot of low molecular weight heparin or unfractionated heparin within 24 hours of surgery. So in this 30,000 patient study, 89.4% had their shot. The incidence of DVT was 1.4%. 11% of the patients refused, or for whatever reason didn't get it. Their incidence was 1.3%. And so in this 30,000 patient study, it was clearly shown that one shot of heparin or low molecular weight heparin didn't do anything. And yet it's interesting that first of all, the results of the CAPS-V trials also show this. And it's amazing how many times, and somebody who's as old as I am, have watched a lot of facts have to be reinvented. It's like reinventing the wheel as time goes on. So that's one thing. The other thing is that there was a group from South America especially, and I worked with them, and they said, you know, it's too hard to collect all these Caprini score elements, and most of these varicose vein patients are not sick. So we put them into categories and collect the lesser scores. And the study that Tomas presented from Poland clearly showed that there were a number of patients in there who were high risk with congestive heart failure and heart disease and cancer. Some of these patients had high risk factors, illustrating the importance of looking at all of the risk factors in the whole score. And again, emphasizing the other category, which is important, and particularly important in this type of surgery. So I'd like to invite everybody to start assaying their population. And oh, by the way, these results that Kiri presented are very similar to results coming out of Wakefield and Obi, who presented their 6-year study of varicose vein treatment and prophylaxis and so forth. So anyway, I would encourage everybody in the future to assay your own results. Find out. Help us. We don't know the answer to this, to pick the exact thresholds for high and highest risk, and we need to find that information out. So I'd like to thank you, gentlemen, for a wonderful discussion, and look forward to seeing you all in the future. Thank you very much.